Okay. So, hello everyone. Welcome to the third day of our webinar series on COVID and immunosuppressive patients. And today we're going to be talking about superinfection and COVID-19. First, I'd like to thank both our presenters today for their availability and to agree to do these talks. And first up, we're going to invite Professor Huyn from University of Pittsburgh. She's going to be talking about fungus superinfection among critically ill patients with COVID-19. Professor Huyn, thank you for...
Thank you. And thank you, Sylvia, for inviting me. It's my great pleasure to talk about one of my favorite topics on earth, which is fungal infections. And now I cannot, okay. I cannot, okay, here you go. So this graph remind me to tell you that compared with the beginning of the pandemic of COVID, the rate of mortality due to COVID has significantly decreased. And this is the CDC data showing the rate of mortality rate from COVID since January of 2020. And the improvement in the outcome of COVID were not only seen in patients in the hospital or as an outpatient, but also was observed among the patients in the ICU, where the mortality rate decreased from 42% down to 19%. I have to stress that although the percentage of mortality are lower, but the number of COVID deaths continue to go up because of the surgence of the cases throughout the US. And as the patient live longer, people are suffering more of the superinfection, and this is what we start to see. The purpose of the conference today is to look at the superinfection after COVID, and my job is mainly to focus on the fungal infections, and Liu Clancy, my colleague, are going to talk about bacterial infections. So to begin the talk today, I would like to review what do we know so far about invasive fungal infection complicating critical ill patient with COVID. So in a nutshell, since January of this year, there have been more than 100 cases of COVID associated with pulmonary aspergillosis, which I will abbreviate and call it as CAPA, COVID-19 associated pulmonary aspergillosis. Most of these cases are probable case, and although they have been increasing in tissue-proven cases, and note that although we call it CAPA, there are few cases were due to other mold, including fusarium as well as mucormycosis. So this slide, I really like it. It just came out from the emergency infectious disease article. And what Karen Moore did this is she summarized all of the report from the beginning of the pandemic up until now. As you can see here, over the past 11 months, most of the cases of fungal infections were reported from China and Europe. In the US, there was only one case series from Johns Hopkins. And I hope that, this is the beginning of many studies that will come out from the US. Unlike the experience with mold infections, the report on yeast infection and candidiasis have not been very well described nor publicized as in the cases of CAPA. Actually, in some hospitals, especially in UK, candidiasis was actually more prevalent than invasive aspergillosis. And candidemia and invasive candidiasis outside of the bloodstream infection have only been reported. The most common species are Candida albicans, although there have been cases of Candida auris was also reported, and the differences in Candida species are mainly geographical difference. And there are also 2 cases of fungemia due to Saccharomyces, and both of these cases occur in the same center among patients who receive a probiotic due to Saccharomyces. So this raised the concern that something happened in severe COVID when the mucosal integrity of the GI tract got broken down. So, whatever pathogen happened in the GI lumen can translocate into the bloodstream and causing infection. So let me start by summarizing our experience on yeast infection. Again, most of these yeast infections are due to invasive candidiasis. There are 2 major studies that actually focus mainly on candidemia. The first one is from a hospital from Italy that just described a descriptive study of candidemia in 21 patients with COVID-19. And they compare with the incidence of the candidemia in the same unit prior to COVID. The incidence rate in the ICU actually was significantly higher among patients with COVID, 82 per 10,000 patient day versus only 15 over 10,000 days in the pre-COVID era. Most of these were due to Candida albicans, and when they look at the demographics of the patient, there were no significant difference in the underlying disease. Although it was mentioned that the COVID patients were more immunocompromised, but they did not define what they meant by immunocompromised. And then the control patient had more solid cancer and were actively on chemotherapy at the time of development of candidemia. The second study was a much better study. Actually, this is a study of 135 patients in multiple center study. And the incidence of invasive candidiasis were about 13%. And when they went back and compared between the patient with no COVID in the pre-COVID era versus post-COVID era, there was a significant jump in the incidence of candidemia, 12% versus 7% among the patient without COVID, and it was statistically significant. And the mortality rate was higher among the patient with candidemia without antifungal, 83% here, versus those who receive appropriate antifungal therapy, which was only 27%. So the question that I ask is, why do we see a significant jump in the incidence of yeast infection among the patient with COVID versus non-COVID? So, after reviewing all the literature, the evidence to date show that the candidiasis complicating COVID is not directly associated with COVID itself, but associated with what we are doing to the patient to treat their underlying COVID disease. All of these patients receive a broad spectrum antibiotic, develop ARDS, got intubated, stay in the ICU for the long time. Some of these patients went on to develop end-stage renal disease. And then, they also receive dexamethasone to treat for the ARDS. And then, some other immune modulating agent. So, these risk factor was very similar to pre-COVID era. What I thought was that the incidence that would increase among the COVID patient are other significant factor. Like I don't know about your hospital, but in our hospital, we put a lot of patients on ECMO. And once the patient on ECMO, there will be other ECMO-related risk factors. These patients, as you can see here, have a long-term femoral cannulation for the ECMO circuit. They have a very high rate of renal failure. And as in this patient, the patient were prone, so there is extensive skin breakdown. And ECMO patients develop a lot of bloodstream infection, so they even receive more broad spectrum antibiotic. And in addition to that, in the early pandemic, when we are really scrunched for room, regular room turned into ICU, and sometimes there's not much space between patients. So the ICU bed cluttering during the COVID-19 pandemic, all of these factors, I think, actually predispose to increased rate of candidiasis among COVID patients. So now I would like to switch to look at the invasive fungal infection complicating critical ill patient with COVID. The incidence rate, again, as I mentioned, all except for one study actually came from China and Europe, and the incidence rate is wide. It's 4% up to as high as 35%. Most of these case series came from the case series. And I think that there might be a lot of problem with these case report as case series. They include heterogeneous patient population with different treatment strategies, from hydroxychloroquine to dexamethasone to other tolisiximab or other immune modulatory agent. The case definition of kappa is a major problem. Some people just go, and if the patient has a single fungal culture in a trach aspirate, they call it fulfill the kappa. Some other people, require other factors. And then there was no systemic screening. Whoever think about this diagnosis just send the biomarkers with no confirmatory test or anything. And then, as I mentioned before, during the very busy time of COVID, the new temporary facility developed with lack of rigorous ventilations. So this might point to the infection control issue where, the environment can be loaded with fungus. So this high rate of IFI is sharply contrast with the autopsy study that we are doing with the investigator in Canada. So what we did was we reviewed 51 study of all the autopsy study up to August of this year, and this study comprised of 702 decedents. And among these, 173 decedents actually were on mechanical ventilation before death, and the incidence of fungal infection of kappa was only 3%. Again, you can see a big difference between the 3% to 35% from the case series. And the take-home message from these cases is that it's not only caused by Aspergillus, but it can be caused by other mold as well. What I think was that the possible explanation for the discrepancy between these rates are twofold. Number one is not much of this autopsy study is a full lung autopsy. They do what they call a needle biopsy at the time of death. So, it may be a hit or miss. The area with a focal fungal infection may be missed because of the needle biopsy. On the other hand, I think that there might be some possibility of overcalling kappa as well. And if you look at the autopsy study for any cause, physician can overcall the nosocomial infection, pneumonia, but when the patient died and went into autopsy, there was no evidence of pneumonia. And the overcall confirmed and explained to us why in the French study, when the rate of fungal infection of kappa in the 35%, most of these patients survive even without antifungal therapy. So unfortunately, at this time, we do not really understand what is the burden of invasive mold infection after COVID-19. There are two studies that I would like to focus on and discuss with you. Both of these studies comprise of more than 100 patients. The first study was from Bologna in Italy. This is a multi-center study. And they use a standardized screening. And one of the things that I like most about this study is that they use actually BAL rather than tracheal aspirate. And they have a standardized time when they do a BAL on this patient. Usually it's on admission and at day 7 or upon respiratory decompensation. And the definition of kappa is that anybody with COVID with pulmonary infiltrate plus one of these factors, either they have a BAL, galactomannan, or a concha, or they have a cavitary infiltrate, regardless whether the concha or galactomannan was positive or not. Based on this definition, the incidence of kappa was 28%. None of these cases turned out to be proven cases. And the median time from admission to the ICU to the diagnosis of kappa is about 4 days. The mortality rate was higher among patients with kappa versus those without kappa, as you can see here. And there was also a trend toward lower mortality among patients with kappa who were appropriately treated with voriconazole. Another study from Well, this is a multi-center study with 135 ICU COVID nation with refractory ARDS. Again, they use a systemic screening. Either everybody got beta-glucan. The majority of patients get beta-glucan and BAL, galactomannan, PCR, and a small percent get own biomarkers. So blood culture, beta-glucan, and also BAL, PCR, and galactomannan. Incidence of kappa in this study is only 14%. And they identify risk factors, which include use of corticosteroid and also chronic respiratory disease. The overall mortality rate is 58%, but this mortality rate is slightly improved if the patient receive appropriate antifungal therapy, going from 58% down to 47%. The big problem with kappa, as I mentioned, is how to establish the diagnosis. If we just base the diagnosis based on BAL culture or trach aspirate culture alone, you will pick up a lot of colonization. And, in these kappa patients, you don't even know whether the chest CT represent severe COVID or is it an underlying fungal infection. Like on this patient here, you can see ground glass opacification and some of the infiltrate. So, you don't even know what is the underlying disease of this kind of CT. So, clinical pictures is very difficult. All of the patients are doing very badly, get intubated, and, you say that they can have a respiratory deterioration, but it's very hard to tell when the patient already maximized on the respiratory support. The radiology finding, as I discussed, and then we can use biomarkers. We can use BAL, the PCR, Aspergillus PCR. These biomarkers cannot differentiate colonization from the invasive disease. All it can tell you is fungus is present with a positive test. So in the CID article by Lou White from the UK, he looked at 16 patients with multiple Aspergillus positive result, with the understanding that if the patient has multiple Aspergillus positive result, it can increase the likelihood of kappa. And as we predicted, the CT was non-specific. They cannot differentiate from COVID pneumonia or kappa in about 50% of the cases. In the other 50%, the patient developed cavity, nodule, or tree in bud. But tree in bud is a very non-specific CT sign for Aspergillus. So, I try to come up with the reason why these people don't have the typical CT guided. And one way that we can explain is to use the damage response framework for microbial pathogenesis, in this case, Aspergillus pathogenesis, as designed by Dr. Casadevone. So in the x-axis, this is the immune. Very weak immunity is over here, and immune hyperactivity is over there. The y-axis is the severity and also the incidence or the rate of these aspergillosis. So on one extreme, in the patient who have a severe and prolonged neutropenia, so the rate of fungal infection is very high, approach about 40%. The CT on this patient reflected the angio invasion and ischemia and also hemorrhage. And you can see here, you can see a pulmonary nodule with early cavitation and also some evidence of ground glass opacification. On the other hand of the spectrum is the hyperactivity or allergic bronchopulmonary aspergillosis. Somewhere in here, among the patient with the so-called decent immune response, you have the chronic necrotizing pulmonary aspergillosis that we see in patients with COPD or emphysema, or you can see aspergilloma. So, the question that we ask is, patient with kappa, where in this spectrum we can put this patient? And right now, we don't know the answer. So, what I think of is we can expand our pathogenesis by looking at the influenza-associated pulmonary aspergillosis. Many of these features, which I call IAPA, are very similar with kappa. Number one is that it affects the patient with no known classical risk factor for immunosuppression. These patients tend to be in the ICU intubated, and the majority of them develop ARDS. And the presentation of note here is pneumonia, but about 30% of these patients can develop a tracheobronchitis with heavy aspergillus plaque, as you can see here, or you can see here. And the rate of aspergillus complicating influenza is about 7 to 28%, and it can affect any from influenza A or B. So when you look at the pathogenesis of aspergillus after influenza, what happened? Influenza, once it inhales from the nasopharynx, once it gets into the bronchial tree, it kind of impair the mucociliary. So, here the virus just kills all of the mucociliary cells to allow the pathogen, including aspergillus, to adhere to this. Because the aspergillus can adhere to the epithelial cells, it can invade and cause the disease. On top of that, the virus in the aspergillus can also cause apoptosis of the epithelial cells, and for that, it exposes the basement membrane. So the aspergillus can go through the basement membrane and start to invade into the lung parenchyma and cause disease. In addition to the local anatomy dysfunction, influenza virus can also cause apoptosis of the T cell and the macrophage. And in some patients, it can cause a strong innate immune response. And we know that part of the innate immune response is IL-10, and IL-10 can cause a negative effect on both the innate and the adaptive response to aspergillus. So overall, then, influenza can cause many things bad to the immune function. So we also know that not only influenza, but other respiratory virus can cause invasive fungal infection as well. So the question is, what about COVID? So, the autopsies so far show that COVID can affect the ciliary function, and this can cause a poor airway clearance, as I showed in the previous picture. The COVID also can cause damage to the airway epithelium, thus, enhance a fungal infection. What we learned very early from the COVID pandemic is that, about up to 80 to 90% of patients with severe COVID have lymphopenia, and lymphocyte is one of the innate immunity that fight against virus and also against aspergillus. A lot of COVID patients receive a glucocorticoid, and all of these patients receive a broad spectrum antibiotic. What I think is that, there might be some unique factors against COVID as well, because COVID caused a lot of immune dysregulation. And as I mentioned before, part of this is it elevate IL-10. And IL-10 decrease the host immune response to aspergillus. And we also know from the autopsy study is that COVID can cause pulmonary endotheliitis and also thrombosis. And, with these pulmonary emboli, it can cause a pulmonary infarction. And the infarction is a very good medium for aspergillus to grow. So I think that, all of these risk factors together predispose a severe COVID patient to invasive aspergillosis. So, I would put that the kappa or IAPA somewhere in around the spectrum. So, what I think is that different CT manifestation due to COVID may reflect the different pathophysiology of aspergillus. And the CT of kappa likely represent a wide spectrum of CT manifestation, ranging anywhere between airway colonization to bronchial or parenchymal lung invasion, and also angio invasion. But remember that if the patient only had airway colonization at the beginning, it doesn't mean that they just stay there. With dexamethasone, with other immune modulator, it can slowly evolve into the more invasive form of the disease. So in conclusion, I think that invasive fungal disease, either from Candida or Aspergillus, can be an important problem among critically ill patients with COVID. Early diagnosis and initiation of appropriate anti-therapy may reduce the overall mortality of this patient. IFI and especially kappa can be very difficult to diagnose. Therefore, we need well-designed and careful epidemiologic study to be able to define the true burden of COVID-19 associated IFI. In the meanwhile, to improve the outcome of our patient, I think we have to start to actively survey for fungal disease and know the local epidemiology of your center, because the knowledge of this might improve the patient outcome. And the study so far suggests that because of the major problem with the diagnosis, maybe combining the testing of multiple biomarkers may be much better than any single biomarkers alone. And for this, we have designed a COVID ECMO screening and treatment algorithm for patients with COVID requiring intubation. This morning, we also met with the MICU patient who did not take care of patient with ECMO to, start to introduce these algorithm into both the patient intubated with COVID requiring ECMO or not requiring ECMO. Okay, thank you so much for your attention. That's all I have.
Thank you, Professor Wing, for your excellent presentation on fungal infection associated with COVID-19. We're going to have some time for questions and remarks after the next presentation. Don't we're gonna leave this for the end. Okay.
Okay.
Okay. Thank you. So up next, we're gonna have. I'd like to invite Professor Clancy. Professor Clancy is also from the University of Pittsburgh. Thank you, Professor Clancy, and he's going to be talking about bacterial superinfections in COVID-19.
Well, great, thank you. So Hong blamed me for messing her slides up when we were practicing earlier. And I can't tell, are my slides up right now?
Yep.
Okay.
Yeah, but we're seeing all of your screen with the
okay. How about that?
Yeah. Now we can see it. Yeah.
Oh, okay. Well, thank you very much. So I'm going to try to make this quick so we can leave time for questions. If you went back a year ago and you look at where we were in infectious diseases, if you went into a time machine, really antimicrobial resistance was at the very top of our worry list. And on November 13th of last year, the CDC released its 2019 update to the antibiotic resistance threat report for the United States. And this got a lot of attention in the United States media. CDC reported there were approximately 3 million antimicrobial resistant bacterial and fungal infections every year in the United States. If you add C. diff in, that number goes above 3 million. And with AMR and C. diff infections, fatalities are 50,000 or more every year in the United States. And of course, a major reason for the emergence of AMR pathogens and C. difficile has been the misuse and overuse of antibiotics. We know that 50% of hospitalized patients in the United States receive an antibiotic. 20 to 30% of the antibiotic days of therapy are inappropriate or unnecessary. And about 20% of patients who get an antibiotic have an adverse event. So antimicrobial stewardship has been a major focus, of course, throughout the world, and the mission of which is to more appropriately use antibiotics, limit their use to cases where they're needed, and to reduce inappropriate use and the consequences of inappropriate use, such as resistance and toxicity. So where do we stand with COVID-19, stewardship, antimicrobial resistance, and superinfections? And that's what I'll talk about. In April, as the first wave was really emerging in the United States, Hong and I wrote a review of the literature up to that point and a perspective piece in clinical infectious diseases, asking what can we expect with superinfections during the course of the pandemic. And, at that point in the literature, mostly from China, about 5 to 25% of hospitalized patients in the reports up till then with COVID had a bacterial or fungal superinfection. These rates were slightly higher among critically ill patients in ICUs. And the microbiology and antimicrobial resistance patterns were likely to reflect institutional ecology, since most of these infections were acquired while in hospital. And then we said that it was likely that widespread broad-spectrum antimicrobial usage during COVID is going to present stewardship challenges. And in the early reports, anywhere from 60 to 100% of hospitalized COVID patients were receiving antibiotics. So since then, a number of reports have come out looking in a bit more detail at superinfections. I'll focus really on the bacterial superinfections with COVID. I think one of the best resources out there, if you haven't seen it, is a website maintained by the University of Toronto, where they do a living rapid review and meta-analysis of superinfections that have been reported. It gets updated every 3 months. And in their first iteration, they had 24 studies with over 3,000 patients. And the overall bacterial superinfection rate among hospitalized COVID patients was 8%, 16% overall among critically ill COVID patients. And about 3/4 of hospitalized COVID patients in the meta-analysis were receiving antibiotics. So what are the superinfections that were reported? A small percentage of them are actually co-infections, which are seen when patients come initially into hospital. And these are usually community-acquired infections, such as community-acquired pneumonia, urinary tract infections, with typical community pathogens. But overall, these account for a vast minority of bacterial infections that are seen in hospitalized COVID patients, the majority are in fact superinfections acquired while the patient is in hospital. And these have predominantly been pneumonia, community-acquired pneumonias, hospital-associated pneumonias, and ventilator-associated pneumonias. And then a smattering of bloodstream infections, urinary tract infections, skin and soft tissue infections, and again, Clostridioides difficile infections. And the pathogens have largely been shaped by, the nosocomial infections that predominate. So we see Staph more so than Streptococcus species or Enterococcus, coagulase negative staph in bloodstream infections. We see a wide range of fermenter and non-fermenter gram-negative bacteria, and all flavors of resistant bacteria have been reported. MRSA, VRE, extended spectrum beta-lactamase producing Enterobacteriaceae, carbapenem-resistant Enterobacteriaceae, resistant Pseudomonas, and resistant pathogens such as Acinetobacter. And Hong has reviewed on the fungal end Candida, Aspergillosis, and less commonly other molds such as Mucorales. When we looked at our experience at VA Pittsburgh, the Veterans Administration healthcare system in Pittsburgh through the end of July, what we found is about 3/4 of our patients in hospital with COVID had no evidence of either a co-infection on admission or a secondary infection during the course of hospitalization. Among the remaining 1/4 of patients who did have some evidence of an infection along with COVID, about 2/3 of those, or about 20% overall, developed a secondary infection while in hospital. And then about 1/3 of these remaining patients, or about 10% overall, actually presented to hospital with a co-infection. And the presenting co-infections were, as I mentioned earlier, we see a lot of veterans who are being treated for cancer. So we saw several cases of febrile neutropenia as well. And then again, the secondary in-hospital infections, hospital and ventilator pneumonias accounting for the majority of them. And our microbiology, as we would have anticipated, pretty much followed our institutional patterns. So in the lung, we were seeing lots of Pseudomonas, Klebsiella, Citrobacter, Stenotrophomonas. In the urine, E. coli, Proteus, Klebsiella. Among these pathogens, we saw MDR, ESBL, and carbapenem resistance infections, as we would expect from our baseline epidemiology. And then the blood, Staph aureus, coag negative staph, some strep species in Enterococcus, and then Candida species. So the other way to look at the data is not with the clinical reports, as I've just reviewed, but as Hong alluded to, you can also look at autopsy data. So in conjunction with Hong and her study of fungal infections, we looked at bacterial superinfections in autopsy studies, 77 studies, over 600 patients who had been reported through September in autopsy series. And what we found is in 10% of autopsies, there was histopathologic proven evidence for bronchopneumonia. And most of these, 8% total, were bacterial bronchopneumonias or infections. And as Huang said, about 2% of patients with fungal infections. However, if you expand the definition, and if you look not only at histologic proven cases, as shown up here in the top left, but also cases where the histopathology could possibly be associated with a bronchopneumonia, but a bug was not recovered or visualized, then about 1/3 of patients have either proven or possible bronchopneumonias or other pulmonary infections upon autopsy reports. Again, similar to the clinical data, in the autopsy data, about 3/4 of patients were treated with antimicrobials of some sort, either antibiotics or antifungals. And in the autopsy literature, the predominant species were Acinetobacter, Staph aureus, Pseudomonas, Klebsiella, E. coli, and then lesser amounts of Streptococcus, Stenotrophomonas, Candida, and Aspergillus. So largely consistent with what had been reported in the clinical reports for superinfections. So the superinfections are there in some minority of patients. Are they actually killing patients with COVID-19? And this is tougher to tell, even in the autopsy series, because it's not altogether clear what a lot of these patients are actually dying of. But in autopsy studies where they ascribed a cause of death, 18% of those patients who had either proven or possible lung infections died due to their superinfection in the investigator's estimation. So if you take the entire cohort of all COVID patients who underwent autopsies, overall about 3% of all patients in autopsy studies died due to either a proven or possible superinfection. So uncommonly the cause of death overall. The major caveats to all this literature, both the autopsy literature and most of the clinical studies to this point, is that superinfections were not really the primary endpoint. And in many cases, there are limited clinical microbiology and treatment data, and there's a lack of standardized definitions or diagnostic criteria that are employed in these studies. So these are not the most robust descriptions of superinfections in the world, but it is what we have. And I think in conclusion, it's fair to say that some appreciable minority of hospitalized COVID patients are going to develop bacterial or less often fungal superinfections, and anywhere from 10% to a third of patients dying with COVID-19 will die with a superinfection, but not necessarily from a superinfection. And in fact, most patients are not dying due to their superinfections. So how about antimicrobial use in a bit more detail? There have been a number of large studies that have been published, as well as that Toronto meta-analysis that I referred to. Out of the University of Michigan, what they found is the majority of patients receiving antibiotics had agents that were targeted against community-acquired pathogens, and in particular, causes of community-acquired pneumonia. So with that, not surprisingly, ceftriaxone was the #1 agent, followed by vancomycin, doxycycline, and cefepime. About a quarter of patients received the drug targeted to MRSA, and about a quarter of patients received the drug targeting Pseudomonas. In another study of ambulatory patients, primarily, the most commonly prescribed agents among inpatients in this series, which was a smaller percentage than the ambulatory patients, were again ceftriaxone, followed by azithromycin, cefepime, piperacillin, tazobactam, and vancomycin. In the overall meta-analysis by Langford, which included in and out inpatients as well as outpatients, fluoroquinolones actually predominated, as you might expect with treating respiratory tract infections in the outpatient setting. We looked at our use again at VA Pittsburgh through the end of the summer. And what we found is that if you look at days of overall antibiotic therapy and bed days of care in our hospital, both of these dropped immediately and precipitously and stayed low at our facility through the end of the summer. But if you actually look at antibiotic use, days of therapy normalized to bed days of care, we actually saw a significant increase. So overall use was down, reflecting the fact there are fewer patients in hospital. But among those patients who are in hospital, they were more likely to receive an inpatient antibiotic. And what we noticed is this was primarily in non-anti-pseudomonal penicillins and macrolides. So in other words, the drugs we're using to treat pneumonia among patients in our hospital. We also looked at nationwide outpatient antimicrobial use in the United States using a nationwide prescription database. We looked at the 10 most commonly prescribed outpatient antibiotics in the US. And what we found is, not surprisingly, in March and April, overall outpatient antibiotic use dropped for all 10 drugs as patients stopped coming to see the doctor. For 6 of the drugs, subsequently, as the summer unfolded, antibiotic use rebounded as people began to make a connection again with the healthcare system. But for 4 antibiotics, the rebound in use over the summer did not come back to the baseline level before COVID. And these included amoxicillin, azithromycin, amoxicillin clavulanate, and levofloxacin. Again, these are primarily used against respiratory tract infections. So there was an immediate drop in the use of treatment of oral agents against respiratory tract infections in the United States in the outpatient setting, and that did not rebound as of the end of the summer. It's unclear to this point what's happened to the U.S. over the course of the fall and the winter now as we're seeing a resurgence in COVID. So what have we done with stewardship? There are really 4 stewardship groups that we've had with patterns of antimicrobial use among our hospitalized patients in Pittsburgh. The first group are people who've gotten no antimicrobials whatsoever. That's been about 40% of our COVID patients. The remaining 60% have received some antibiotics. The largest group were started empirically. There was no definitive infection diagnosed, but they were started generally to treat community-acquired pneumonia. That was about 30%. About 10% of our patients were treated on admission for a co-infection. And then in the final group, about 20% of our patients were treated for a secondary infection that developed while in the hospital. So with that, we could devise stewardship strategies targeted toward each of these groups. So if there's no evidence for secondary infection, the stewardship objective is to withhold antibiotics and to intervene early in the emergency department or in the wards so that the drugs aren't started. And rapid diagnostics with high negative predictive values, such as procalcitonin, might be useful in this setting. For those patients who present with a co-infection, you want to give empiric agents directed against the most likely pathogens for infections like community-acquired pneumonia and like UTI, and then rapidly de-escalate once you know what's going on. If you present with a documented co-infection, then you want to use the most narrow agent possible against the known pathogen and promote short course and, if possible, oral treatment. And then finally, if you develop a secondary infection while in the hospital, then you're going to use your empiric agents against your most likely pathogens based on your local epidemiology. And again, promote narrow coverage as quickly as possible and short course regimens. So really, I think for all stewardship programs during COVID, the objectives are to track and report your local trends and to understand them in the context of regional trends, to make sure you're appropriately using COVID-19 directed therapies. So, how you're using your remdesivir and other drugs, educating your healthcare worker colleagues as to proper use of antibiotics, adverse drug monitoring, and putting together decision support approaches, treatment pathways, and stewardship practices that make best use of your local resources and target your local antimicrobial use and resistance patterns. So finally, will COVID-19 result in increased AMR? And we don't really know the answer to this. You can make a pro and con argument on either side of the issue. And we published in Journal of Antimicrobial Chemotherapy, AMR, a month or two ago, a debate with Peter Collignon of Australia as to whether we thought there would be increased AMR or not. We took the pro side. You can see some of the points that we made. Collignon and his colleague, Dr. Beggs, argued against. And we're just going to have to see as the pandemic continues to unfold what happens globally with AMR. But one thing I do want to talk about as an argument for why we will see increased AMR with COVID is this, which is reports of hospital-acquired infection and AMR outbreaks associated with breakdowns in infection prevention due to the strains placed on staff and resources by COVID-19. And we're seeing now a number of reports throughout the world of multi-drug resistant bacteria, as well as resistant fungi like Candida auris, emerging in hospitals that have dealt with a lot of COVID, have had a lot of pressure on their infection prevention staffs, and have had resulting outbreaks with hospital-acquired and AMR pathogens. Here is the first report I saw, which is an NDM, New Delhi metallobetalactamase producing carbapenem-resistant Enterobacteriaceae outbreak in a hospital in Tuscany in March to May at the very beginning of the pandemic, where they found that the risk of NDM, carbapenem-resistant Enterobacteriaceae acquisition, was threefold higher in their COVID patients than in non-COVID patients, and that these were associated with longer lengths of stay. Overall, about 14% of their COVID patients became colonized with an MDM CRA, and about a quarter of the colonized patients developed invasive infections with these pathogens. So I think it's fair to say that COVID and antimicrobial resistance, this is going to be a dynamic story. I think AMR is likely to differ from region to region, hospital to hospital, and unit to unit within hospitals. But regardless, AMR was a major problem before COVID, and it's going to remain a problem during COVID and after COVID. So in conclusion, bacterial and fungal superinfections are going to occur, I think, depending on your hospital anywhere from 5 to 33% of patients at given hospitals based on the literature so far. It's going to be more common in the critically ill patients. Overall, nosocomial infections are going to be more common than community onset infections present upon presentation to the hospital. The microbiology in AMR is going to reflect your institutional and local ecology, but be careful, look out for nosocomial outbreaks and local spread that may occur due to breakdowns in infection prevention. Widespread broad-spectrum antimicrobial usage is going to be common. It's going to present stewardship challenges. I think your stewardship approaches need to be tailored to your local epidemiology and your local antimicrobial usage patterns and local resources. So finally, what do we need to do? I think all of us need to report our own experiences and data. I think in general, we need studies that make more rigorous use of microbiology and definitions of superinfections. We need more surveillance data at local, national, and international levels on antimicrobial use in AMR. And we need to educate both our clinical colleagues and our patients and families. In most patients with COVID, particularly in the outpatient setting, it's okay not to get and give an antibiotic. And no matter what happens in the short term, AMR is not going to go away. And we need to keep on top of both AMR and good stewardship practices. So with that, I'll stop. I hope we have some time for questions. I think we got off to a late start with the computer problems. So, I'm happy to entertain any questions that we have time for. Thank you.
Right. Thank you, Professor Clancy, for your excellent presentation. And we do have some time for questions. So I'd like to open now for discussion. If anyone has questions to ask or any remarks. Right. So first, Professor Quinn, I'd like to ask you. You said that you were surveilling all patients that underwent ECMO for invasive fungal infection. So how often do you screen these patients? Are you using galactomannan serum and BAL for them, or are there other criteria for high-risk patients? What's the periodicity of this surveillance?
So, the surveillance is not only for the epidemiology purpose, but also for early intervention. So, what our program is that when the patient get intubated, we will need a sample, beta-D-glucan, serum galactomannan, and also BAL if we can get it. Otherwise, it would be a blind BAL or tract aspirate. I really prefer a blind BAL because people just don't want to do a bronchoscopy procedure. So that is, within 24 hours of intubation, and then weekly after that, we put in our protocol that whenever the patient decompensate. So, if they have a hemodynamically decompensation, it's easy, right? We know that the blood pressure go down, we have to use pressors. But if we define a respiratory decompensation, it's very difficult because most of these patients are maxed out on the ventilator anyway. So we do weekly, and whenever there is a decompensation. What we start to see a lot is that beta-D-glucan just come back positive, and we don't know what to do with it because we know that septic patients, they have some degree of gut ischemia or mucositis. So what we have been added for the past 2 weeks is we add the colonization index. So, once a week, we call it Monday is our mushroom day. That's when we get all the biomarkers. We do colonization index in the BAL and also in the stool. And then, whenever the positive result come back, we will use the algorithm to guide the physician of when to decide on antifungal therapy.
What drugs are you using to as the choice for treating the possible invasive fungal infection? Are you choosing?
So if it's candida concern, so beta-glucan or a patient with hypotension or septic shock, I prefer to use the fluconazole. But to tell you the truth, once patient on ECMO, they have a liver toxicity with azone, so it's out. So you are talking about caspofungin for candida, and if you're concerned about mold other than aspergillus, then we have no choice. Or even with aspergillus, if the LFTs liver function tests are really bad, we go to liposomal FOB.
Okay, thank you. And Professor Clancy, you said that there's a minority of cases that you saw with the bacterial superinfections when they're coming to the hospital, and we see that the patients usually they have some C-reactive protein with very elevated levels. Are you using any other biomarkers to diagnose bacterial infection or to stop treatment or like procalcitonin?
So actually, in our practice, we're not. And I think the reason for that is that in the first wave in the United States and in the second wave over the summer in the United States, Pittsburgh is really not hit as hard as a lot of other regions of the country. And the number of patients and the burden was such that we were able to, with our stewardship team at VA Pittsburgh, consult and give advice on a case-by-case basis. And with that, we did not put together any testing algorithms or what have you. I think the literature on using biomarkers is still kind of emerging, and people have different opinions about them. I would say our colleagues across town at AGH, the other big healthcare system in Pittsburgh, have made very, very aggressive use of procalcitonin in their COVID patients. And what Dr. Walsh and his team have found is it's been very useful for them, particularly in people when they present to the emergency department, in avoiding antibiotic treatment for potential community-acquired pneumonias in COVID patients by relying on the negative procalcitonin level. Other people, particularly in hospitalized patients, have felt like procalcitonin is positive too often for it really to be useful for them in ICUs, in particular with discontinuing antibacterial. So I think the literature at this point is inconclusive, but I think what it shows you is that tailoring approaches to different populations is probably going to be what's needed. And the way you approach your emergency room patients and your patients on the medical floor is probably going to be different than the way you'll have to approach the treatment stewardship of patients in intensive care units. I would ask what has experience been for other people in terms of what you've seen with superinfections, both bacterial and fungal, and whether you're on the high end or the low end of the ranges that I presented or that Dr. Wynn reviewed for fungal infection.
Fungal infection, você tem algum dado? I'm not sure what our fungal infection incidence is here in our hospital. We do have the bacterial incidence. Do you know what it is? And I think we had some difficulty with the stewardship here, because when the whole hospital was turned into a COVID unit, the largest building here in our hospital was turned for COVID patients. And most of the patients, when they came to the hospital, they all received empiric treatment for pulmonary infection as for pulmonary pathogens with ceftriaxone and azithromycin. And there was a big push for macrolides here. So we had there was implementation here, and Silvia was one of the ones that pushed for the implementation of procalcitonin here, and we didn't use it before, and now we had implemented this in our routine to help guide that with the help of our consult team, with the IT consult team, talking to the intensive care doctors and the emergency room. So we had to work on a case by case, but we also had to implement some kind of have to have proof that there was something that you could show the doctor, because otherwise they're going to say, but we have the C-reactive protein that was over the top, and we still have to, you cannot be sure that there isn't a bacterial superinfection, so we're going to keep doing using the antibiotic. So we had to kind of work around these issues here.
So was the procalcitonin helpful for discontinuing or not using antibiotics? That's what Tom Walsh and AGH in Pittsburgh have found. They found it very useful, especially in the emergency department. I think what you're touching upon, though, is true in that it's easy to put together stewardship pathways and restrict antibiotic use when you're not overwhelmed with COVID. I think what happens when you get beyond a certain threshold and you start getting overwhelmed and strained with COVID, then stewardship, then infection prevention, all these things become a lot more difficult to do. And I do think we were lucky in Pittsburgh in that early on we did not get hit hard. We were able to put protocols in place, and we were able to have our stewardship on top of every case. And we were able to, see that about 40% of patients didn't receive any antibiotics at all. And a lot of patients who did get antibiotics were off antibiotics within 48 hours after we figured out, what was going on and felt comfortable stopping them. But if you're going to run a hospital where there's hundreds of COVID patients and everyone is running around, your units are packed, it becomes very, very, very difficult to do this.
True. And I have another question for both of you. We're talking about COVID-19 immunosuppressed patients here. So did you experience any finding that the transplant patients had an increased risk for superinfections, either fungal or bacterial, or is your impression that it's the same as everyone else, as the general population?
Again, so on the solid organ transplant population, I think that the superinfection is no more than other patients. But we see like two different population in the hospital. Those who came in, we gave a steroid, they got better quickly, they went home. The other one is that they decompensate, got intubated, and stay in the hospital for a long time. And what we see, nosocomial infections is the majority of those patients, especially pneumonia. But we do not see much difference between the solid organ transplant with severe COVID versus the other one. Versus the non-transplant, they fare just the same. But more people on the solid organ transplant die from COVID than other patients.
All right, thank you. If anyone has any other questions, or feel free to ask right now.
How bad is COVID in Sao Paulo? Was it a lot?
It's increasing again here. So all even here in our hospital, we're seeing all the ICU beds that they're starting to filling up again, and we still have two wards that were kept just for the COVID patients, but we're always receiving new patients because we're a reference center, and the private hospitals here are all full, so to deal with the new increase of cases again.
So the data out of Manaus got a lot of attention in the United States. Or are you doing a bit better than they are overall? I think I'm looking at maybe 76%. I think it was had been infected.
Oh, you mean the community spread of the?
Yeah, right. I'm sorry. Yeah, I'm not asking about transplant specifically, but just in general in Sao Paulo.
I think we did better than you said Manaus, right? The
Manaus data.
Their healthcare system almost collapsed back in the first wave of infections. Here we did build some. They called campaign hospitals or something like that. They converted some places that were used for a conference or even the soccer stadium. The soccer stadium was converted to a hospital to receive COVID-19 patients. So there was, I think that got the brunt of the burden of disease, and we didn't collapse. So we did better than other places, I think. But now that all these hospitals were closed after there was a decrease in cases, and we're seeing a rise again, and we're not sure how we're going to respond after that. And we're worried because there's the holiday season coming up, and everyone.
A lot of people. You've got a lot of people.
In the news, recently in the news, there was lots and lots of people going out to the street shops for Christmas shopping, and it's like one person of the other. So we're kind of worried what's the consequence of this going to be.
Yeah, well, your leader, like our leader, has taken a less aggressive approach than some other countries.
Yeah.
Yes. Yeah. So it is really a big problem because we don't have a real leader right now. So it's really a mess here. And as United States, the states, they has their own problem. So São Paulo, in my opinion, is the well-organized state in Brazil. So we are doing okay, but depends on the state and the region. If it's a poor region, that depends more on the federal government, they will be in real trouble, as the north of Brazil, that's poor and nearby Amazon jungle. So, yes, very difficult time.
Yeah.
Okay.
So, I'd like to thank you guys and the University of Pittsburgh. It was a great honor for us to have you here in our webinar. Excellent lectures, and the lecture will be available on YouTube, and people will access. And so, thanks so much indeed. And I know that's a difficult time, but I wish you a great whole Christmas at home, alone. People should avoid to prevent the spread of SARS-CoV-2, and I hope so next year we can meet you guys again in a conference in the end of the year. Let's see what will happen.
Yeah, maybe we can come down to Brazil. That would be very nice.
Yes, I hope so.
Okay, Merry Christmas.
Okay, yeah.
And
take care.
And stay safe.
Merry Christmas, Happy New Year. Yes, stay safe. Bye-bye.
Bye-bye.
Stay safe. Bye-bye.
Thank you.
Bye-bye. Thank you all.
Nós estamos ainda no YouTube?
Duas vezes.
Precisa terminar a transmissão.
Não, mas é que está atrasado.
Tá?
As direções.
Então tá bom. Maravilha.